Okay, now coming towards anorectal abscess, we have started our systemic surgery and we have started the lower GIT portion. And half of it is discussed already in our first video. The rest of the section we will discuss in this video. So we are having the first topic, that is anorectal abscess. We are having a scenario that there is 30 years old patient, anal pain for last 36 hours is present, pain progressively getting worse, uncomfortable to work or sit down. So what are the rectal examination? No, the rectal examination reveals swelling at end margin, anal margin. What is the diagnosis, the causes, the classification and the treatment? So the causes of anorectal abscess are infection of anal glands found in intersphincteric plane, that is 60% E. coli, 23% is due to Staphylococcus aureus. Trauma is also the cause, and STD is also the cause, that is sexually transmitted diseases. Now, what is the classification? This is perianal, ischiorectal, rectal, intersphincteric, and pelvirectal or supra-elevator. This is the broad classification of anorectal abscess. Now, we are having the clinical features, that is manifold swelling at anal. Then ischiorectal abscess may communicate posteriorly to form horseshoe abscess, deep pain, mimic pelvic peritonitis. What are the treatment options? These are incision and drainage, antibiotics, perianal and ischiorectal abscess, intersphincteric and supra-elevator abscess, horseshoe abscess, analgesics and antipyretics. The perianal and ischiorectal abscess drained by cruciate incision, and the intersphincteric and supra-elevator abscess are drained by rectal canal. So we have discussed the anorectal abscess, its scenario, then causes, then the major classification, then the clinical features, and then the treatment options. Now coming towards the anorectal fistula, we are having a scenario that there is a 40-year-old male, fluctuant tender swelling is present on lateral to anus and subsides after drainage of pus. So what are the investigations, management and classification? We are having a definition that okay, we are having a definition of anorectal fistula that okay. The scenario for anorectal fistula is that there is 40-year-old male, fluctuant tender swelling. Okay, we have already read the scenario. Now coming towards the definition. There is fistula in ano is a tract lined by granulation tissue which connects deeply the anal galar or rectum and superficially to skin around anal opening. The causes are hemorrhoidal sclerotherapy, infected hematoma, carcinoma, Crohn's disease, tuberculosis, and immunosuppression. The clinical features are intermittent purulent discharge and pain. On examination, raised granulation and multiple external openings are present. We are having parts classification, that is intersphincteric fistula is 45%, transsphincteric is 40%, suprasphincteric fistula and extrasphincteric fistula. The investigations are clinical, ultrasound and MRI. The treatment options are fistulotomy, fistulectomy, seton and colostomy. In fistulectomy, fistula tract is laid open. Fistulectomy, fistula tract is excised. Seton is a surgical thread and colostomy is high and complicated fistula. Feces are diverted away from fistula tract. So we have discussed the anorectal fistula, its scenario, then the definition, then the causes, the clinical features, then the part classification and the on examination, and then the investigations, and then the treatment. Now coming towards the hernia. Having a scenario that there is a 35-year-old male patient, pain in right groin for last 2 months, which was on exertion, swelling in right groin, and more on standing, and cupping disappear on lying down. So the diagnosis is inguinal hernia. Now what are the differential diagnosis, the complication, treatment, management, anatomy of inguinal canal, further clinical tests to diagnose difference between direct and indirect inguinal hernia, and the post-op complications. So the definition is that hernia is abnormal protrusion of a cavity's content through a weakness in wall of cavity but take with it all linings of the cavity. There are 3 parts of hernia. This is sac, covering of the sac, and contents of the sac. Now the clinical classification of hernia, we are having reducible hernia, irreducible hernia, obstructed hernia, and strangulated hernia. The obstructed hernia is irreducible. Bowel is obstructed, but there is no interference to blood supply of bowel. In strangulated hernia, blood supply is compromised. Colicky, abdominal pain, nausea, and vomiting is present. On examination, tense, extremely tender, irreducible with no expansile cuff impulse is present. The common hernias are inguinal hernia, femoral hernia, umbilical hernia, paraumbilical hernia, and epigastric hernia. So up till now we have discussed that what is hernia and what is the definition, then what are the different parts of hernia, then what is the clinical classification of the hernia, and what are common hernias. Now we will discuss the common hernias one by one. The first one is inguinal hernia. So for inguinal hernia, first we will discuss the anatomy. We are having inguinal triangle, which is also called Hazelbeck's triangle, through which direct inguinal hernia protrudes. It consists of medial border, superolateral border, and inferior border. The medial border is lateral margin of rectus sheath, also called linea semulinaris. The superolateral border is inferior epigastric vessels. Inferior border inguinal ligament, sometimes referred as Pupert's ligament. Then we are having the inguinal canal. Inguinal canal is 3.75 cm directed downwards and medially from deep to superficial inguinal ring. It has got superficial inguinal ring and a deep inguinal ring. Superficial inguinal ring is triangular opening in aponeurosis of external oblique muscle which lies 1.25 cm above medial to pubic tubercle. And then the deep inguinal ring, which is oval shaped ring in transversalis fascia, lies 1.25 cm above inguinal ligament midway between symphysis pubis and anterior superior iliac spine. Now coming towards the boundaries of inguinal canal, these are anterior boundary, posterior boundary, superior boundary, and inferior boundary. The anterior boundary is formed by external oblique aponeurosis. Posterior boundary is formed by fascia transversalis and conjoint tendon. Superior body is formed by conjoint muscles, and inferior boundary is formed by inguinal ligaments. So we have discussed the anatomy of the inguinal canal or inguinal hernia, the boundaries, the canal, and the inguinal triangle. Now coming towards the different types of inguinal hernia, which are direct and indirect inguinal hernia. The direct inguinal hernia bulges through inguinal triangle, that is Hazelbeck's triangle, into inguinal canal, and then through superficial inguinal ring into the scrotum. The indirect inguinal canal loops of bowel or omentum passes through persistence of patent process vaginalis, deep inguinal ring, inguinal canal, and then through superficial inguinal ring to reach into the scrotum. The different types are bubonocele, the furnicular, and the complete. The bubonocele is limited to inguinal canal. The furnicular is the processus vaginalis, is closed just above epididymis, and contents of sac can be felt separately from the testes. The complete indirect inguinal hernia is reaches to the bottom of scrotum and testes lies within the lower part of hernia. Okay, now the direct inguinal hernia is common in old age with weak abdominal muscles. It is less common. Hernial sac bulges forward through posterior wall of the inguinal canal, medial to inferior epigastric vessels. Hernial sac runs parallel to the spermatic cord. The indirect inguinal hernia results from persistent patency of the processus vaginalis, which is most common in children and young adults. Hernial sac enters the inguinal canal through a deep inguinal ring and lateral to the inferior epigastric vessels. The hernial sac lies within the spermatic cord. Now, the direct inguinal hernia is common in middle age. Growing pain fails to reach scrotum, reduce on lying lies posterior medial to spermatic cord. Bilateral broad neck occlusion test is negative. Impulse on fingertip and not strangulated. The indirect inguinal hernia is common in young age. Groin pain is present, reaches scrotum, not reducible, lies anterior lateral to spermatic cord. Unilateral nerve of neck ring occlusion test is positive. Impulse on finger pulse, and it can be strangulated. Now coming towards the clinical features, these are swelling, asymmetry, inguinal hernia which passes into the scrotum, passes above and medial to pubic tubercle in contrast to a femoral hernia which bulges below and lateral to tubercle. The differential diagnosis in males is vaginal hydrocele, encysted hydrocele of the cord, femoral hernia, undescended testis, and lipoma of the cord in female, hydrocele of canal of neck, and femoral hernia. Now, the complications of hernia are that it is irreducible, obstruction is present, strangulation, perforation, and peritonitis. The treatment options are, first of all, we are having the pre-op treatment, that is FBC, chest X-ray, sedatives, nil per oral for 6 to 7 hours. ECG is done. Intravenous antibiotics are given. Analgesics, urine RE, RBS, and catheterization is done. Laparoscopic herniorrhaphy is done, which contain the transabdominal pneumoperitoneum approach and the total extraperitoneal approach. Treatment of inguinal hernia is surgery. Surgical operation comprises of two components, herniotomy and herniorrhaphy. Now, the herniotomy is excision of the hernial sac and herniorrhaphy is a repair. The inguinal herniotomy, it is performed for indirect hernia. Oblique incision is made in skin and subcutaneous tissue above to the middle two-thirds of the inguinal ligaments. External oblique aponeurosis is incised in the line of its fibers, and structures beneath it are carefully separated before completing the incision through superficial inguinal ring. Inguinal canal is opened after incision given to extend oblique aponeurosis. The content of inguinal canal can be visualized in canal and then identify the sac and then reduce the sac by emptying them. The wound closure is then done. External oblique aponeurosis is closed and external ring is reconstructed. Scarpas, fascia, and skin are closed too. The second method is herniorrhaphy. It is strengthening of the posterior wall of inguinal canal. Prosthetic mesh is used or are repaired by sutures. It is done to pressure recurrence of inguinal canal. Now the methods are like this method: Bassini's repair, Scholdi's repair, Maloney-Dent repair, and ledge tension mesh repair. Now coming towards the direct inguinal hernia. The sac does not pass through the deep inguinal ring. Instead, the sac passes through a weakness or defect of the transversalis fascia in posterior wall of the inguinal canal. The treatment options for direct inguinal hernia are the surgery is the way of treatment. Principles of operation are as that of indirect hernia. Instead of doing herniotomy, sac is simply inverted after it has been dissected free. Herniorrhaphy is done by Rickenstein repair. The complications of herniotomy or herniorrhaphy are hematoma, seroma, wound infection, hydrocele of the hernial sac, recurrence of the hernia, bladder injury, and injury to vas. Now coming towards the strangulated inguinal hernia. We are having a scenario that there is a male patient which is presented in emergency room with painful swelling in the right inguinoscrotal region associated with pain, abdomen, vomiting, abdominal distension, and absolute constipation for days. On examination, swelling is tense, tender, and irreducible. What is the diagnosis and management? So, for strangulated inguinal hernia, common indirect inguinal hernia, it is irreducible, plus there is obstruction and blood supply is compromised. The clinical features are symptoms and signs. The symptoms are sudden pain, colicky pain, and vomiting. The signs are tense, extremely tender, irreducible, and no expansile cough. The treatment options are urgent surgical repair after adequate resuscitation. Intravenous fluids are given, nasogastric aspiration is done, appropriate antibiotics are given, and monitoring of the urine output is done. The management options are admit the patient, resuscitate the patient, give intravenous fluids and analgesics and intravenous antibiotics, that is metronidazole plus cephalosporins, nil per oral, then catheterize plus suction of gastric contents is done. Then inguinal incision is given. External oblique is open in line of fibers. Incision is given without mobilization of spermatic cord, so contaminated fluid don't go to peritoneal cavity. Constriction is usually a deep ring of the neck at the sac, and it may be superficial ring. Strangulation may be due to addition between sac, and strangulation may be of momentum or small intestine. The point of constriction is released and contents are withdrawn. If it is momentum, it is incised, but if it is small intestine, viability is checked. If viable, put back in abdominal cavity. If not viable, then resection plus primary anastomosis is done. Now, sliding inguinal hernia. The posterior wall of sac is not formed of peritoneum alone, but by sigmoid colon and its mesentery on left, the cecum on right, and sometimes on either side by a portion of the bladder. The complications of sliding inguinal hernia are that these hernias can easily strangulate, and since its wall contents include large intestinal mortality and morbidity increase. The treatment options are surgical repair is treatment of choice. During surgery, not necessary to remove any part of sliding hernial sac. It should be freed completely from cord and abdominal wall. No attempt should be made to dissect the cecum or colon free from peritoneum because of high risk of perforation. Femoral hernia. 50 years old patient presents with vomiting, abdominal pain. On examination, lump is present in the groin which is stented and is below and is lateral to pubic tubercle. What are the differential diagnosis and discuss the management? Another scenario is that there is 30 years old woman, 2 days history of abdominal pain and diarrhea. Abdominal examination reveals mild lower abdominal mass. Examinations reveal tender irreducible swelling below ligament and little to pubic tubercle. What are the management options? Femoral hernia, third most common type of hernia, occurs just below inguinal ligament when abdominal contents pass through a naturally occurring weakness called canal. Femoral canal or boundaries. These are anterior, posterior, medial, and lateral. The anterior femoral canal boundaries are inguinal ligament, the posterior are ilioperitoneal ligament, the medial are lateral ligament, and the lateral are thin sputum separating it from femoral vein. Now, the clinical features are 20 years of age and more on the left side. The differential diagnoses are inguinal hernia, saphenous variceps, enlarged femoral lymph node, lipoma, femoral aneurysm, psoas abscess, distended psoas bursa, rupture of the adductor longus with hematoma formation. The investigations are clinically diagnosis and ultrasound, CT scan, MRI, and plain X-ray that show small bowel obstruction. The management are resuscitate the patient, give intravenous fluids and antibiotics, analgesics, empty bladder, and catheterized surgical repair is treatment of femoral hernias. It includes three approaches: low, high, and inguinal and laparoscopic approach. In low approach, simplest operation for femoral hernia, suitable only when no bowel dissection is present, performed under local anesthesia. Transverse incision is made over hernia sac is opened and see the contents. Reduce the content, non-absorbable sutures placed between inguinal ligament above and fascia overlying the bone below, not possible in strangulated hernia. Then we are having the high approach, which is complex operation, ideal in emergency situation where risk of bowel strangulation is high, done under regional or general anesthesia. Classically, vertical incision is given in lower abdomen, central at lateral edge of the rectus muscles. Anterior rectus sheath is incised and rectus muscles displaced medially. Hernia is reduced. Sac is open to allow careful inspection of the bowel, and femoral defect is closed with sutures, mesh, or plug. Now we are having inguinal approach. Give inguinal incision and elevate the flap. Then dissect and open the sac. If contents are strangulated, open transverse fascia and reduce hernia. If there is gangrene, it needs bowel dissection after opening peritoneum. Once reduced, neck of the hernia is closed with sutures or mesh plug penetrating the iliac vein through it. Then the laparoscopic approach. Both total extraperitoneal and transabdominal periperitoneal approach can be used for femoral hernia, and standard mesh is inserted. Ideal approach of the reducible hernia. Now the scenario, we are having the paraumbilical hernia. The scenario is that there is a 50 years old obese lady often on pain is present swelling in umbilical region or 1 year, sometimes aggravate on straining and relief on lying down. So what is the diagnosis, the complications, and the management? So paraumbilical hernia is a protrusion through the linea alba just above or sometimes just below umbilicus. In adults, not occur through umbilical scan. Increase in size and can become very large. Neck of the sac is remarkably narrow as compared with the size of the sac. The causes are 50 to 60 years age, obesity with flabby abdominal muscles, repeated pregnancies, and ascites in cirrhotic patient. The clinical features are swelling around the umbilicus, swelling increase with coughing and straining. It is reducible, dragging pain due to presence of momentum, and strangulation is common. The management options are because of high risk of strangulation, so surgery should be advised if sac contains bowel loop. Small asymptomatic hernia can be left as such. Surgery, open or laparoscopic surgery. We are having myo repair, mesh repair, anatomical repair, and reduction of the weight. We are having the Richter's hernia. When only part of circumference of bowel becomes strangulated, it is called Richter's hernia. It may be reduced, gangrene may be overlooked at operation. Femoral hernia or obturator hernia are a few examples of hernia which can be sometimes presented as Richter's hernia. The differential diagnosis of lump in groin are inguinal hernia, femoral hernia, epididymitis, testicular torsion, varicocele, hydrocele, saphenous varix, psoas abscess, femoral artery aneurysm, and lymph nodes. Now, irreducible hernia. When hernia can't return to the abdominal cavity when pushed in, they can be chronic, although painless, and can lead to strangulation, obstruction, or both. We are having irreducible and strangulated. The irreducible are not reducible, not strangulation, no obstruction, additions between sac, no pain, and cuff impulses positive. The strangulated are not reducible, strangulation is positive, obstruction is positive, narrowness of the neck of the sac and tender, and cuff impulse is negative. So up till now we have discussed the hernia. Before moving forward, let's revise this, as the hernia is a little bit complex and very important topic in the field of systemic surgery. So this is the hernia. First, we discuss that what is hernia and the scenario for hernia. Then we discuss the definition and the parts of the hernia. Then the major classification, which is broadly classified into four classes: reducible, irreducible, obstructed, and strangulated hernia. Then what are the common hernias? We go through a general idea that it is inguinal hernia, femoral hernia, umbilical, para-umbilical, and epigastric. Now we are discussing one by one in detail. First of all, we are having inguinal hernia. So first we discuss the anatomy of the inguinal hernia, which is inguinal canal, and it is having medial, superolateral, and inferior border. Then the inguinal canal, which is superficial inguinal ring and deep inguinal ring, and then the boundaries of the inguinal canal, which are anterior, posterior, superior, and inferior. So this was the general anatomy of the inguinal hernia. Then we discuss the two major broad classes of the inguinal hernia, which are direct inguinal hernia and indirect inguinal hernia. We discuss the general definition and then the clinical features, and then what are the common or important points. So the clinical features and the differential diagnosis in male and female of the inguinal hernia, and what are the complications of hernia. Then we discuss the treatment options. First of all, we have pre-op treatment, then the laparoscopic herniorrhaphy, in which we are having transabdominal pneumoperitoneum approach and total extraperitoneal approach. Then for the treatment, we are having herniotomy and herniorrhaphy, inguinal herniotomy and herniorrhaphy. We discuss it. Then the direct inguinal hernia. Then we discuss the direct inguinal hernia. Okay. The treatment options. Then the complications. Okay. Treatment complications, and then we come towards the strangulated hernia. We discuss its scenario, then the clinical features, that is symptoms and signs, then the treatment and the management, and then we discuss the sliding inguinal hernia and the complications for the side and the treatment. Then we discuss the femoral hernia and the scenario for the femoral hernia and femoral canal boundaries, clinical features, differential diagnosis and investigations, management, low approach, high approach, and inguinal approach, and laparoscopic approach. Then we discuss the scenario for the para-umbilical hernia, and then we discuss its causes, clinical features, and management. Then we discuss that what is Richard's hernia and the DDs of the lump in groin, irreducible hernia, and the strangulated hernia. Now we are coming towards our last topic, that is Meckel's diverticulum of the lower GIT. Scenario that there is a 14 years old patient present with 24 hours history of increasing pain in the right iliac fossa. Diagnosis of acute appendicitis was made. At operation, appendix was found to be normal and a Meckel's diverticulum was found in distal ileum. What are the characteristics of Meckel's diverticulum? What are the complications and the treatment? So first we will read the definition, that is Meckel's diverticulum occurs due to failure of obliteration of vitilo-intestinal duct in 5th or 6th week of the fetal life. It is true diverticulum containing all three layers of the bowel wall, and it is situated in an antimesenteric border of the terminal area. Now we are having the rule of 2 for Meckel's diverticulum, that is incidence is 2%, male to female ratio is 2%. Symptomatic from 2 years of age, and it contains two types of mucosa. Then the clinical features of Meckel diverticulum are severe hemorrhage, that is 30 to 50% bleeding per rectum. Then Meckel's diverticulitis symptoms like acute appendicitis, pain around the umbilicus, intestinal obstruction, and chronic peptic ulceration. Then we are having the investigation options, that is technetium scan, identify ectopic gastric mucosa. Then the contrast studies is done, that is small bowel following through may detect diverticulum. Then angiography is done to localize the bleeding. The treatment options are bleeding, that is ongoing loss of the blood are detected. Endoscopy is done to rule out upper GI bleed. If Meckel's is the cause of bleeding, then segmental resection of the ileum including Meckel's diverticulum and adjacent ileum peptic ulcers should be performed. Then the diverticulitis encountered when person is undergoing surgery for preserved appendicitis and the appendix is normal. Terminal ileum must be inspected for Meckel's diverticulum. If present, should be resected. Then for obstruction should be relieved along with resection of the ileal segment containing diverticulum and end-to-end anastomosis. Then incidental, if suspicious for tumor or narrow, then diverticulectomy should be performed. So the last topic that we are having in the lower GIT is Meckel's diverticulum. We have discussed the scenario, then the definition, then the rule of 2, then the clinical features and the investigation, then the treatment specifically for the bleeding, for the diverticulitis, and for the obstruction, and then for the incidental Meckel's diverticulum. In the next section, we will discuss the urology. I will try to complete the last unit of the systemic surgery, that is urology, in just a single video. And then we will complete the systemic surgery subject and we will start our next subject. Thanks for watching.